Okay, are we still, Deborah and Shawan, are there more people
No.
coming in?
No.
Okay, so maybe we'll get started because we only have 2 hours, and I think there's just so much exchange that needs to happen that people would like to happen. So we'll get going. Thanks to all of you who've joined us. And before I begin, I want to acknowledge that McGill University and the MUHC are located on unceded Indigenous lands, and that Montreal was historically known as a gathering place for many First Nations. I want to express my gratitude and my appreciation to those on whose territory our place of healing now stands. Far from this being just a formality, I hope that this acknowledgement will serve as a reminder that Indigenous people, along with a host of other underserviced, marginalized, and racialized communities, continue to face additional and very enormous barriers to accessing healthcare. As patient advocate, it's our duty to ensure that the voice of all who are in need are heard, are represented, and are amplified. So I'm just going to give you a little bit of a rundown in what I hope to accomplish in the next 2 hours. First of all, is everybody comfortable in English? Est-ce que tout le monde est confortable en anglais? Si on continue en anglais? So if there's no objection, I'm going to continue because I know that we do have some members who are more comfortable in English. So we'll start off. I'd like to introduce the members of the MUHC Users Committee. Then I'd like to get introductions from all of you. You are not obliged to introduce yourself, but it would be we would be very grateful if you would. What I'd like you to do, if you're interested, is to just put your name in the chat. This will allow us to be a little bit more efficient. We will just run down the names in the chat. We won't leave anybody out. There won't be any of those sort of uncomfortable pauses. Everybody's waiting for the next person to speak. So we'll go with that. So put your name in the chart, in the chat. If you have a preferred pronoun, please put that in as well. Just one note about the chat. Number one, I'm not really able to multitask very well. And number two, I have some vision issues, so I will not be able to kind of monitor the chat. I know Shawan and Deborah will hopefully help me do that, but I would much prefer to have your questions and comments and everything at the end in person, if possible. But of course, if you prefer to use the chat, you're more than welcome to do that. In between, if you're not speaking, I ask that you mute yourselves. There's always a lot of ambient background noise, which sometimes makes it a little bit hard to hear. And also, if you don't object to keeping your camera on, that would really be great. So after your introductions, I want to go over a little bit about how our users committee is going to be structured and how we hope to function moving forward. And then I want to move on. I know there are a number of people who want to make various presentations about your activities, projects, anything else that you'd like to share. So we've heard about those in advance. Even if you're not on that list, if we have time, we welcome input from pretty much anyone. And then the remaining time will be really just devoted to discussion, questions, comments, suggestions, exchanges, ideas, really anything that you want to share with us. Deborah, anything I'm missing before we start with our introductions?
No, I think that's good.
So yes, okay. So my name is Ingrid Kovic. I am the new chair of the MUHC Users Committee. This is actually my first time on this sort of users' rights committee, though I have been involved for the past 7 or 8 years on various open science initiatives at the Neuro as a patient advocate, and also I sit on the governance board for the Neuro's open science tissue repository. And I became involved because around that time I developed a very rare neuromuscular disease, which affects pretty much all organ systems. So I've had many different treatments, over 10 surgeries in the last few years, multiple admissions. I've been admitted to the ICU over 30 times. So I'm a fairly heavy user across 5 of the MUHC sites. Prior to that, I worked for 20 years in a small Cree community in northern Quebec called Miscagonish. We lived there on a permanent basis for the first 5 years. So my kids grew up speaking Cree. or at least the older ones grew up speaking Cree. And then we continued to work there part-time back and forth between Montreal and Waskaganish for the next 15 years, till I developed this condition and was no longer, unfortunately, able to travel or to be in a remote area. And so here I am. Next, I want to hand the floor over to Deborah Radcliffe-Branch, who is our amazing vice chair.
Hi, everybody. I know so many of you. It's nice to see your faces again. My name is Deborah. My history with the MUHC goes back for about 10 years. I ran a program called My Toolbox, which many of you may have heard about. And I also have quite an extensive experience as a cancer patient. I developed many complications and had to be hospitalized at various sites. So I'm quite familiar with all of the different sites as well, and familiar with the cancer experience, both as I actually did my doctorate degree with patient education with cancer patients. So I know it from an academic perspective and from a lived perspective. So hopefully I can bring that knowledge forward and help the Patients Committee achieve its goals. Thank you.
Okay, we also have our secretary, Amanda Berkovich, who is in transit from Toronto. Are you still there, Amanda, and able to introduce yourself?
Yes, I'm here. Can everyone hear me?
Yes.
Yes.
Okay, hi. So sorry, my camera's not on. I'm on the way back from Toronto, but my name is Amanda Berkovich. I got involved with the User Rights Committee because my son had a long NICU stay at the Children's Hospital. He was premature. So that is how I came to this committee. I'm also a lawyer, a practicing lawyer. I practice in Montreal. I work at the Bank of Nova Scotia as legal counsel, and I'm also the secretary of the committee.
So the committee is basically very lucky that we have our own counsel in the form of Amanda. Okay, Joe. Pass it on to Joe.
Hi. Basically, I'm a patient. I'm a transplant patient. I've been transplanted now for 30 years from a kidney transplant. I've been quite dedicated for a long time on Patients Committee, originally at the Royal Victoria Hospital. I was part of the first transition to the Central Committee. Didn't last for long, but anyhow, I also run an organization called Dialitran. I'm the chairperson. Basically, we run services for mainly for dialysis patients. We try to make their lives easier when they're doing their treatments, but we haven't been functioning since COVID. We're hopefully going to be starting again shortly. And anyhow, since I owe my life to the institutions, and you know, really want that the patients get the best care possible, that's what we're there for. So that's it. And I'm also your chair, the person in charge of your finances.
Yeah, that's it. So Joe's our treasurer. We were happy to have his financial brain on board and grateful for that. Shari Newdorf. Oh, is Shari still here with us? Or?
You're muted, Sherry.
He's muted.
Shari, you're muted.
Better?
Yeah.
Yes.
Hi, my name is Shari, and about 6 months before COVID hit, my husband was diagnosed with metastatic melanoma, and became, a caregiver of him, and spending a lot of time with him in the hospital, learning to navigate my way through for him, for us. And in that process, I became interested in getting involved. And that's basically how I came to this committee. But I have no experience sitting on a committee. So I'm kind of a novice, learning a lot, but hopefully we'll be able to contribute.
We are grateful to have you. Thank you. Sarah Cohen.
Hi, everybody. I'm Sarah, I first started working on the Montreal General Patients' Rights Committee, and I began there because I saw a poster advertising them. And of course, by the age of 50 or 60, whatever I was, I had been a patient many times, had stories to tell, and really didn't want other people to have to tell the same stories if it could possibly be avoided. So I became a member of the Patients' Rights Committee, and from there to the present CUC, which I'm very proud to be a member of.
Thanks, Sarah. And Danielle.
Yeah. Hi, folks. I know some of you. I'm Danielle Carter. I live in Lachine. I am a patient partner, patient partenaire, but I was on a committee. Now I'm on this user committee here, the Central User Committee, the CUC. I was brought into it, taking care of both of my parents who have since passed away. So that's how I was introduced into participating and becoming involved in hospital activities.
Thanks, Danielle. So that is the full users committee for the time being. That being said, we will soon have an addition to our committee in the form of a designated member from the residence committee at Pavillon Camille Lefebvre. Their elections for their committee are ending, I believe, today at noon. So they will be constituted in a way that conforms to the Act very shortly, and then they will designate another member to our committee. And I will let everyone know who that is as soon as I have that information. Okay, I would love to hear from all of you. I'm just looking in the chat. I see Falk Kaiser, number one. So go ahead, Falk.
Hello, everybody. I think I know most of you, and I've had the privilege of seeing the new CUC in some of the training sessions at the RPCU. I'm the English trainer for the RPCU. I'm also a patient advocate, both in Quebec and some areas in Canada and down in the US as well. I have sat on the CUC several years ago, and I still sit on the Montreal Neuro. And I'm thrilled to see the new committee come aboard and welcome you and wish you much success.
Thanks very much, Falk. Joanne Moselle.
Hi, yeah, I'm Joanne Moselle, is right. I sit on the Neuro Users Committee, and my motivation for doing that is because I'm coming from the rare disease space. My son has a very rare, extremely complex disorder. I have some experience in patient partnership, mostly in research with research community across Canada and actually other places too, in the States and in Europe. And I'll also be presenting hopefully short presentation from the accessibility committee that I've been attending for about a year. Thank you.
Thanks, Joanne. Mona.
Hi, I'm part of the Royal Vic Users Committee, and I've been on that committee for about 5 years. Well, since the Royal Vic started here, so I guess it is 5 years. And I have been a patient of the Montreal Neuro with post-polio, and also a patient of the Royal Vic, and I'm on the board, and I'm very interested in helping out with the Royal Vic. We need a lot of help, and that's where I can easily get to. I'm a wheelchair user, and I'm very interested in helping patients have their rights.
Thanks, Mona. Thank you. I see Elizabeth is working and maybe in and out. So I don't know if Elizabeth, you're here at the moment, if you're able to introduce yourself. I guess not. Okay, so let's get back to her. I guess, did she have her camera on when she was present? Did anyone notice? No. Okay. Mary Jo.
Good afternoon. I'm Mary Jo. So I'm most and foremost a patient of the MUHC for the last 29 years. I was diagnosed with a neurological condition, MS, which developed other complications, and I became a full user of the services across the MUHC, at the RVH, at the Montreal General. I had to, be seen by different specialists, and I'm still being followed after all these years. About 15 years ago, I decided to get involved as a volunteer. So I became a volunteer at the Neuro, and that led me into user committees. I then became a patient partner, which I am still a volunteer. I'm still a patient partner, and I am no longer, of course, the ex-chair of the Neuro Users Committee, since it's no longer active. But the Neuro User Committee members are all volunteers at the Neuro, and we're all, engaged in volunteering. So, and that's what I've been doing for the last 29 years as a patient.
Thanks, Mary Jo.
Welcome.
Dean Williams.
Hello, everybody. I'm originally from Toronto, grew up there, university, decided to come to an exciting city, Montreal, yes. Worked as a psych nurse for many, many years. Did a degree in library studies, master's, because I needed the challenge, and have been on the RVH Patients Committee for a number of years, particularly because of my interest is admission. It's the borders, the admission and the discharge. It's community. Our patients don't live in hospital; they live in the community. And how are we in the hospital making it as easy as possible for them? I became involved with Bonnie and a woman, Linda DeLeo, an Indigenous woman from the South Shore, around the brochure. And this happened about 3 years ago. We had heard about Brian Sinclair, an Indigenous man dying in the emergency room in a Winnipeg hospital, and then the tragedy of Joyce Aishiquan. And the reason we know about the bullying and the racism around the 37-year-old Joyce Aishiquan was because she took a video. We know Indigenous people are being maltreated across the country. It's everywhere. And so I'll tell a little bit more later, but we developed a brochure about patients' rights, and that's an area of focus for me right now. Thank you.
Thanks, Jane. And yes, to speak to the fact that had she not taken that video, and for all those who suffer the same and do not take the videos, we need to speak up. So thank you for sharing that. Robert Goodrow.
Yes, I'm involved with the Montreal General Hospital's Patients Committee. I've been a member for about 4.5 years now. I've been a volunteer at the General for close to 13 years, especially with the auxiliary. And as a patient with the MUHC, I am a patient in the respirology department of the Montreal Chest, and also in the hematology department for, I would say, minor issues. They're certainly not life-threatening. And my goal with the General especially, or principally, is for the care and comfort of patients. And I'm hoping Tom McCutcheon will speak up. He and I are currently working on 2 really good projects at the General to do with dialysis and to do with the renovations on the 15th floor. And I'll let Tom go further into that. Thank you.
Thanks, Robert. Yeah, we do have you guys down to present a little bit about that later on. So these are all the names that I have from the chat, but I see there are more people present. Is there anyone else who would like to introduce themselves? Bonnie, did I see your hand? Sorry. Yeah, go ahead.
You're on mute, Bonnie. You're still, oh. You're still on mute.
You're muted.
Bonnie, there's an easy way. Just press on your space tab and keep your finger
Okay,
on it.
got
You'll be
it.
on-
Yeah, right, got it. A little
Thank
slow on the thing. Well,
Thanks.
I've been also on the RVH Patient Users Committee, as well as I was chair of the medical mission, which actually didn't take place while I was there. But I have been a patient and member of the Montreal Children's and Royal Victoria Hospital for many years. And I've had an open heart surgery and I've gone through quite a bit. However, my whole interest to join was because I am a physiotherapist. And when this building was first built, the RVH was, the new building was built. There were a lot of problems in there for wheelchairs and accessibility. So this is what brought me in. But my background is I was working with at the MUHC Center for children with disabilities and deaf children. And then this led me to be very interested in the deaf and to see how we could make some changes, improve life for them. Apart from that, I think that's all I could say. Thank you.
Perfect. Thank you. I think we'll be talking a little bit more about the project and the report and recommendations for the deaf community later on. Thomas McCutcheon.
Yes, I'm Tom McCutcheon. I've been a member of the Patients Committee for over 15 years now. I started with the Montreal Neuro and moved on to the General. I'm also a patient. I still at the Neuro, at the General, at the Vic, and also at 5100 the Maisonneuve. So pretty well all-around patient at the MUHC. I hope that we've been all introducing ourselves pretty well. Thank you for all the people that introduced themselves. And I'll be presenting a little later on about some stuff that's been happening at the General as part of the Patients Committee of the MUHC. Thank you.
Thanks, Tom. Lawrence, did you have your hand up?
Well, just to introduce myself, Lawrence Reach, I'm a volunteer at the Neuro. I've been a patient there since 2009. I've had 3 brain tumor surgeries there and radiation treatments. And my neurosurgeon suggested that I get involved as a volunteer in a hospital. And I've been on the users committee, and it's been very fulfilling, and I enjoy the work.
Thank you. Anyone else? There are a few people whose names I see, but cameras are not on. So I think you can't really raise your hand, but anyone is welcome to join in. Are we done?
I noticed Harvey on the telephone is not listed in the chat.
Okay,
So,
thank you. Sure. Harvey, would you like to introduce yourself? You're muted. I don't know what if you can adjust that. Okay. Anyone else? Okay, so maybe we'll just go on, but please don't be shy if you are just joining or have changed your mind to say a few words at any point where there's a pause.
Someone just rejoined, so maybe that person.
Maybe is that Elizabeth or
Patricia.
Patricia Kerr.
okay. 6 will mute on phone. Okay, I'm just looking in the chat. Someone, I guess, is just trying to explain how to unmute by the phone.
*6 to unmute on phone.
Yeah.
Apparently. Harvey, if you want to unmute yourself on your phone.
Anyway, let's go on, and then hopefully we will inspire the rest of you to introduce yourself at a later time. So before I begin to describe our structure and governance and how we'd like to see our community function in collaboration with those that already exist and with those that we hope will soon exist, because we hope there will be a great number of these, I want to acknowledge how frustrating this past year must have been for everyone here. I was aware that the CUC had been dissolved, but I was really not aware that all the other subcommittees had been dissolved as well. And so I can really only imagine how frustrating and infuriating it must have been, especially listening to all of you and your years of commitment and devotion and the numerous projects you've worked on, to have all of that suspended. I just really want to recognize that that must have been very, very difficult. In any case, I'm eager to see all of that recede in the rearview mirror, and I am really excited to get all committees up and running, projects back up and running, and working together collaboratively. And really, that's what we hope to foster, which is a spirit of collaboration, both within individual communities, but also between our communities. And we hope to have ongoing, open, and productive communication that happens not only at meetings such as this, but in between, because these meetings are few and far between, relatively speaking, and there are long intervals between, and we hope that we can communicate and exchange and move forward with projects in between all the meetings. We hope that the partnership that we can establish is going to be not only fruitful, but also collegial and also gratifying. We're all here as volunteers. We are all juggling not just enormous responsibilities as they pertain to our committees, but also numerous life responsibilities and health issues and other considerations. So I think it's reasonable to expect that 100% of our energy be directed constructively at ensuring the best possible care for our patients and the best possible services that are offered and the best possible living conditions for those residents whose home is within the MUHC community. So in sorting out, since this is a new committee, we were all beginning anew, and in sorting out our governance and how we want it to be structured and function, there were two main drivers that we considered. The first is that we need to conform strictly to the Act respecting health and social services. The second is that we really want to avoid any and all conflicts of interest, any partisanship, and any other division that might cause strife. And so those were really our two guiding principles. And to that end, there are a couple of technical points and governance issues that I want to just go over because I think they might be a little bit different than what existed before. So the first relates to terminology, and it's driven home by all the terminology that I see that we are all using here and some changes that we'd like to see. So again, since I started from scratch, I reviewed, hundreds of pages in the Act, many different government frameworks and guidelines, and I could not find anything that related or applied to or referenced a central users committee. There was a CUC that was referenced, but they referred to a continuing users committee. There was an ICUC, which referred to an integrated centers user committee, but there was no central users committee. And I realized that this is a unique moniker that was spawned within the MUHC to address the fact that there were so many other user committees. And this is an issue that really should have been addressed 25 years ago in 1997 when the MUHC merged. So what happens is it took individual institutions each of which, or most of whom, had their own user committees, and it now merged into a single institution. As per the Act, each institution is permitted only a single users committee. So theoretically, 25 years ago, the structure of all these committees should have changed to reflect and to conform to the Act, and it did not. And so because these other user committees or patients rights committees, the names sort of kept going, I guess there became a need to distinguish the users committee, and thus was born the term Central Users Committee. But we would like to go back and start it in a way that conforms to the Act from the get-go. So again, under the Act, the MUHC is a single institution. There is a single users committee, and that is the one that was formerly known as the Central Users Committee. So we are going to continue forward using the term Users Committee for our committee. All the other committees, we would request that you find a title that suits your mission, but that avoids either Users Committee or Patients Committee. User and patient seems to be, at least in English, used interchangeably. So the confusion persists if you use either Users Committee or Patients Committee. So obviously the Family Advisory Forum is no problem, is fine. There's no confusion. But all the other committees, we would really ask that you try to find another title that represents the mission and is accurate, but that does not confuse your committee with the Users Committee, because we are dropping the central and we are staying in conformity with the Act. I know this is a hassle. I know there's going to be an adjustment period. Members of our own committee still refer to ourselves as the CUC. I'm sure the terminology will be confusing for a while, but we have to start somewhere. And I think moving forward, it will all be straightened out in a matter of months. So I apologize for the bit of a hassle with that, but we are obliged to conform to the Act, which has not been the case for the last 25 years. But moving forward, I think we should all be on board with making that a priority. Now, beyond the title of your committee, there is absolutely nothing else that will change in terms of the functioning. We are not going to impose any dictates on how you work, whether you have bylaws, what your bylaws state, whether you choose to go without bylaws, whether you choose to elect an executive, whether you choose to forgo an executive, how frequently you want to meet, how you want to conduct the meetings. Whatever method and whatever system works best to allow your committee to be as productive and functional as possible is what we want you to do, and we will support it. So other than title, there is no practical changing in how the committees function, and we want you to do what works for you. Before I continue, Deborah, any comments or anything I left out with regards to items?
When we were brainstorming and trying to think of possible names, we did think of advocacy committees. So for instance, the Royal Vic Advocacy Committee, but that's up to you. That's a decision that you should make.
Right. We came up, advocacy committee, advocacy council, rights council. I mean, there's, it's sort of limitless, and absolutely that is your decision to take. Falk, go ahead.
I have a question, and maybe it's too early to ask, but one of the questions in the old format, which was contrary to the MSS rules, there were strings attached to budgets for certain interest. Just given the names are changed, would some of these advocacy or missions ask the central for a small budget? And one thing I would also advise is perhaps you as Swan as an administrator share the Zoom function for some meetings, because you have to have a professional Zoom which costs money out of pocket, but your Zoom can be given to all different committees, and it's very, very easy to allow one or two people of those missions to use the Zoom as well. So maybe the budget and the virtual media, maybe you can address that, Ingrid.
Sure, I was going to later, but I'll get to budget right away. So again, we are abiding by the Act. So as per the Act, each users committee of the institution, which is the entire MUHC, in which there's one users committee, is allocated X number of dollars per year. From that amount, $1,000 per annum is directed by the ministry to be allocated to our residence committee at Camille Lefebvre. Beyond that, the budget is for us to do with as we like. The vast majority of it goes towards paying our administrative assistant. I will submit that is money exceedingly well spent, but it does not leave us with a great deal of extra budget. Now, I understand in the past, because again of the carryover of autonomous users committees within the user committee and the conflation of all of this, that there was a certain budget allocated per committee. We were planning to not specifically allocate budgets per committees, partially because we hope to have far more than the 7 historic committees. We feel that there are enormous number of needs, whether we're talking about the deaf community, Indigenous populations, mental health rights. I mean, so many different groups, and we'd like to see them all represented. And clearly there's no budget for simply allocating blindly to each one. But we do want to be able to support specific projects. And so what we're going to ask is that any committee come to us with an application for funding of whatever project that you that requires funding. You know, we've been working very hard for 4 months, doing a lot. So far, none of it has actually required funding. So much of the work we do does not require funding, some does. In lieu of simply allocating the same amount to what might be an infinite number of committees, we ask that you come and apply with a specific project in mind and a specific request for a specific amount of funding, and we will evaluate it. That being said, Zoom accounts for all. I mean, there's no question that every committee must have a Zoom account. That is a no-brainer. If you want it, you've got it. I wasn't aware that we could share it without paying for individual accounts, and maybe we can talk about that after. But irrespective, even if we have to pay individual accounts for each subcommittee, there is no question that will be covered. And in general, any project that has merit, that requires funding, if we have the funding, the money will be there. It's just from year to year, there may be one committee that requires funding for several projects or a larger chunk of funding, and there may be others who don't require any funding. And so it did not make sense for us to just allocate a fixed amount per committee. Go ahead, Joe.
So 2 things, if you don't mind me interjecting on what you're saying. So there is a better account that we can purchase, a piggyback, so that each committee has an account. Because if we allow them to share ours, then it's in conflict with this guy and that one and the other thing. So that's very complicated. So we can buy a bigger license that allows more users. So we'll have Chauvin look into that. And the next thing I wanted to interject is, as much we just want everyone to understand the money that is allocated to us on a yearly basis is a very small amount. Again, Ingrid, explained that most of our budget is already taken. So just bear that in mind when asking, and any reasonable request will not, I think the committee will definitely look into it with merit.
Yeah, I agree with all. So, so that's the funding. That's the structure that we hope to work with. Now, also, I will, concede up front. This is the governance, the structure, the functioning that we imagine is going to work well. We are in the process of amending our bylaws to reflect what we hope to achieve and our mission and how we hope to function. but nothing is written in stone. If we find that what we imagined would work well does not, we will revisit. If members of, other advocacy committees, if any of you, if people are troubled by the functioning or how things are structured, please don't be shy, raise your concerns. Again, we are not fixed with any of this. This is just how we imagine this at this early stage to function best, to number one, conform to the act, and number two, to prevent any strife within committees. So again, we hope to have many, many more than the 7 historic committees. But in our efforts to avoid all conflicts of interest and all partisanship, no user committee member will sit as a member on any of these other, hopefully many, committees. That being said, we hope that your committees, you may desire, see fit to invite one or more of us to sit as an observer. This can be for each meeting, this can be for some meetings, this can be for parts of some meetings, whatever you see fit. So whatever way we can help you improve communication with us, we're open to doing. But we will not be sitting on, if you sit on the users committee, we are not going to be partisan, and we are not going to be sitting on any other specific committees. Again, partially because we hope to have very many and there are only X number of us, but also because we really do want to prevent the partisanship and the divisiveness that might happen. Similarly, if ever that you have something that you'd like to share, if something you'd like to present to our committee, you need only ask for an invitation to our next meeting. We will invite you, and you will be able to, designate a representative from your committee and join us and present or share ideas or discuss as you like. Again, this should not be the only time that we communicate, but certainly is one of the times, especially if you want to present something a little bit more formally. Funding we have covered. Okay. Deborah, any comments with?
Not that I can think of, no.
Okay, so Residence Committee, I was going to update you. We're pretty much updated, so hopefully they will be up and running soon. And I think that is a really crucial committee that to address the needs of, as we discussed, patients whose home is here at the MUHC, who's not, who are not just eating lousy food for the duration of an admission, but who actually live, within the MUHC. So it will be really great to have a very strong and powerful voice from them and for them. Okay, so moving on to presentations, I have an MGH presentation. Actually, I'll go through the ones that I have, and if anybody else wants to add a little presentation or spiel, please go ahead. So I have one from the MGH, the Accessibility Committee presentation, which Joanne spoke about earlier. Jean talking about the welcoming brochure, Bonnie, the Deaf Project, and Harvey about traditional foods. Anybody else have anything they'd like to add?
I'd just like.
Oh yeah, go ahead.
I'd just like to present to you later one of the programs that we do at the Neuro that the other institutions might be interested in.
That's great. Okay, add it. Yeah, so this is exactly the setting. These do not have to be big, huge projects, whatever, but this is our chance to let other committees know what's going on, what we're doing, to benefit from other people's efforts, to spawn and inspire efforts of our own. So that's exactly the type of thing that I would love if people would share. Okay, so MGH, I don't know if it's Tom or Robert or both.
Yeah, I'll start. Just gonna go over some of the feelings and some of the attitude and some of our accomplishment that we did as a committee at the General. Our patient committee has always taken our role as a very serious and had a good team. And we did our work with nothing else but the patient in mind. We always did all our activity towards the patient that was in-house, and also for the clinic visiting patient, and to facilitate and render it easy and more pleasant their stay or visit at the hospital. That's always been our end of thought and mission, is the patient, and making it easy for that patient to go through whatever they were going through. We also did this for the family and the visitors. And we thought that we were always doing this, our activity, by the rules and the regulation and the guidelines of the CUC and the government mandate for the users committee. We had an office, for example, there, and we use our office to meet patients, advise them on their rights, receive their complaints, guide them to the ombudsman, which is down the hall from our office. So it was a good and easy task to do. And we needed to, and then we needed to follow the complaints to the office of the CUC at the Glen, which we did. We also like this to state some of our action and activity, even if some people didn't always look at what we're doing as something that we should have taken on. We push very hard in the administration. And one example is when we install or push the administration to install air conditioning to the patient, we push the administration for over 175 AC installed. And that was done in a year and a half instead of 3 years. So that was, and it wouldn't have been done if there would have been any push from the patients committee. It wouldn't have happened that quick. And it wouldn't have happened probably at all at one time. It's hard to make people understand why we talk about air conditioning in a hospital. And I'm going to let you know, if you sit somewhere else and you're not walking the floor there and you don't see the nurses going through with their clothing stuck to their body because of the sweat and the heat, and then you walk in front of a patient's room and you see that poor patient laying in the bed without a sheet on because it's too hot to have a sheet on top of them just to sit there all day long at 100+ degrees. You can't judge and you can't feel if you only hear about it through an email or something. If you see it, you feel it. If you sit in an air-conditioned room and you hear on an email or by somebody who's wondering about that, it's so hot that the clothes are sticking to you, you don't get the same feeling. You got to walk the floor. And that's why we were walking the floor and we saw that and we thought it was one of the best things to do for the patients. And also it helped the staff. When the staff is happier, they work better. When they work better, the patients are better off. It all rolls down one thing to the other. It just makes sense. Anyway, that was one of the things, just by being there. We also pushed the administration to fix handicap bathrooms, the restroom. And everybody said, well, what are you doing with doors in the restroom? Well, when you find out that patients with handicap, a wheelchair trying to get into a bathroom, and they get stuck in the door because the wheelchairs are bigger than what they used to be, and the door, maybe not at new hospital because of different ways that they build them now, but the older hospital, the doors were much smaller, much more narrow for the simple reason they didn't have those big wheelchairs years and years ago. Our hospital has been built for over almost 100 years. So let's put it this way, there's not the same guideline to build now than what they were then. And it's just something that you don't see as part of the directive from the government and a mandate as the patients committee to try to push administration to fix bathroom door, you know. We also work and just simple thing, a seat in the X-ray changing room. On the 5th floor, you're going to see there's cubicles for 4 in a row, and there's 8 of them. for people to go and change for x-rays. Well, if you try to change, if you got a mobility problem, you stand up, you try to undo your shoe, put your pants back on or take them off, standing up in a very small cubicle, you can fall very easy. Your head hits the wall. It's very unpleasant. We ended up we pushed them, getting up to them to build a little seat so people could sit and put their clothes on while they were doing that. Simple thing that wouldn't have been done without the patients committee. I can tell you that it wouldn't have been done without the patients committee. We pushed to install new signs. People say, well, what's the sign in hospitals? All kinds of signs. Yeah, they were very hard to read and to follow. Most of us know that when the new Glen was built, one of the biggest problems right from the beginning was the signage problem. And nobody could understand them. Nobody could follow them. They were very complicated. Well, the old sign were also complicated and out of whack. And they still had old signs guiding you to a department that was no longer there. They had moved different floors and the sign weren't changed. So easy little things that means a lot to an awful lot of people. If you walk hospital corridors are usually pretty long, and if you got mobility problem, there you go again. You walk all the way down there to tell you that it's not there, it's on a different floor now, it's moved because you're just following the old signs. It's just things that had to be done. We also work on getting a complete changing cabin or a room with a door and a heater in there. And I don't know if I got the right word, but it was on the 4th floor where patient had to go and have their picture taken before they can be authorized to have a bariatric operation. They had to supply pictures to the government to authorize the cost of a bariatric operation. These poor patients were sitting there on a stool in an open room to get undressed. It takes away all your human feeling that is, what am I, a piece of, sit on a little stool, not even a good chair to sit on to dress and get undressed. And these people are not easily mobile too. It's very awkward to some. And then they go outside there and sit in front of a camera with no privacy. I think we also did some little kits with patients that come in, and mostly homeless people. They come in, they get to the ER, they get to some floors, they have nothing. If they're kept there, no toothbrush, no toothpaste, no face cloth, no this, no that. We build those little kits, and we gave over 400 of those. So we still got some, we're still doing it. I think it makes if ever you're there and somebody doesn't have anything, and you got this little kit that doesn't cost much to us, and you give it, and just to see the smile on the patient that receives it, and it makes you feel so damn good. I think everybody would like to be part of that and see the feeling that these patients, just a smile they give you. It's just being a bit more human, and I think it's worth our while to keep it up and keep going. It we'll probably resupply it, and that probably be one of our first demand on the new committee for allocations of fund. Might as well put it in right now. We get a chance. It won't be in writing for a while, but you'll hear about it now, so you'll know when you see it. I think we can still maybe keep doing some of the stuff we've been doing. Our heart's in the right place. If we get to a place where we feel that we are doing something for the patient with the new committees, with the feeling that we're part of a bigger team and it all works out well, I'll be fine. I just like to add something that all patients committee and everybody involved with patient better be very vigilant in the future, for the simple fact that we're going to go through another reform at the hospital, obviously with the CAC, with their new reform. I think we went through those that are part of the old committees and that are still there. We went through one reform with the Badet reform, and we kind of know how that affected a lot of patients. With the changing of this, the changing of that, nobody knew where to go, how to, that was going to be done. A lot of promises. It's not easy. So my feeling is that we're going to keep going if we are allowed to keep going the way we were going, maybe not with the same lane, maybe not with the same all around partners or whatever we want to call. But as long as we can keep doing some good stuff for the patient, because our mission is, as a patient's committee, is the patient advocate, whatever the name is, whatever it is. I think the mission is still the patient. The end name on all our commitment is the patient. So let's keep going. And now I'm on the 15th floor. I'm just going to go a little ahead. What we're doing right now is that we're finding funds to help staff purchase some stuff that they can't get from the administration because they don't have the funds, they don't have the budget. They're doing a lot of work on the 15th floor, and the managers, the nurse managers, ask the patients committee if we can help them find funds to buy some stuff that they can't get within their own budget. And we did, and we found some. It's not part of the patients committee fund, but it's funds that they can use. We ended up getting them that floor, just $34,000 to buy special air mattress for patients that they can be better stay in their bed for a long time, long period. The 15th floor, we call it a heavy floor, which patient that needs a little bit more care and not fit enough yet to go home or to go in a home. We got special wheelchair that patient could be sitting to be going from this and that instead of a stretcher. They got a wheelchair that can be moved in different angles to make them more comfortable, and take them out of the bed and put them in that wheelchair and move them to a window to the without laying in the bed again. And it's easier because of their condition. They can lay on the side or have their feet higher than anything else. It's a very flexible type wheelchair, and it's great. And they also have special table that they wanted to feed patients instead of regular straight table that goes on top of their on top of the bed when they feed them. These special tables are articulating a lot of different ways with different stages of the table, so that the food is there, the drinks is there, the dishes, the different things are different level, easier for patient to use. So anyway, that's part of the things that the patients committee or our ex-patients committee is doing. It doesn't have to be within the guidelines of the government to the patients committee, but if it does suit the fact that it helps patient, we can do it. Let's do it. I'll let Bob explain some other thing that is being done, and it's also part of us that is doing it, because the request came to us basically as patients committee first. And Bob, if you're there.
Sure.
Go on.
Tom neglected to mention that he tours the floors on a regular basis, probably once a month. He knows all the nurse managers, and they're the main point of contact for providing these services, these projects. So Tom is working closely with the foundation and the auxiliary for these funds for the 15th floor renovation. The auxiliary does have the money, as does we're fortunate we have our own foundation as well. And Tom has a really good rapport with them. And the other major project right now that we're working with, it's purely with the auxiliary, it's on dialysis. And the auxiliary has targeted dialysis as a main project for the next few years. We're starting off with baby steps and purchasing new chairs. And it was because of Tom that the auxiliary and the patients committee, I should say, that the auxiliary was able to move forward on the dialysis project. But I want to reiterate, Tom takes the time, he makes the time, and he contacts the nurse managers face to face on a regular basis. And this is a big plus in addressing patient needs. Thank you.
I can say thank you, Bob, but I can say the reason I contact the nurse manager, if you don't do that, you don't know. They don't come to you all the time to ask you for stuff. And if you don't go on the floor, you don't see things, you don't hear things. And I mean, the word of mouth is the best publication you can have, the best publicity you can have. And to me, that's the way to do it. So that's the way I do it. And thank God I'm able to get the help like from the auxiliary or from the foundation to do these projects. It's pleasing to see that it's happening.
Okay, well, thanks to both of you and also to the entire MGH committee. It's really an impressive laundry list, and I say that in the most positive way, of impressive accomplishments. I think we can all appreciate how difficult it is to get anything done, let alone achieve really impressive actions that have meaningful impact on patients' experiences and patients' care lives. So thanks to your entire committee, however you want to name yourself. It does not change your mission. It does not change what you've done and what I hope you will continue to do. It's very impressive. And on behalf of a patient who's experienced, who's benefited from your efforts, and on behalf of the entire MUHC community, we thank you, because it's really a job well done. So thank you for that.
Thank you.
Accessibility committee.
Hi. Yeah, okay. So I just wanted to just for the purpose of a little bit of background, my interest really is in epilepsy and implementing innovations in care of epilepsy. And so I went to the quality, I've been looking for a place to voice, and I went to quality improvement, and then they directed me to the accessibility committee. So epilepsy may still be one of those new committees that will come to pass later on. But so I've been sitting on the accessibility committee, and I'll just have a brief listing of the activities that they've been doing. They've been very involved in. So the accessibility committee is an MUHC committee responsible for elaborating and implementing le plan d'action à l'égard des personnes handicapées. It's a mandatory action plan submitted yearly to l'Office des personnes handicapées du Québec. The committee is co-led by Valentine Weber of Multidisciplinary Services and Stephen Yamamoto from Technical Services. It consists of members from different job titles, services, and sites. These include communications, advisor for EDI. EDI is equity, diversity, and inclusion. Librarian, human resources, communications, and legal affairs, as well as 2 patient partners, including myself. Recent presentations made to the committee include the Lachine Hospital renovation expansion presented by the project manager and architect planner. Another was on the Programme Médico-Juridique. So this program has been running at the Montreal Children's Hospital to help patients navigate legal issues related to their health care. Through a social worker, access to médico-juridique lawyers is made available. Training on the programs is available to MUHC staff members, and the committee is supporting extending the program to the adult sites if funds are available. So it's been going really well at the children's, and so they were asking for consensus on whether they wanted to extend it to the adult sites as well, which we all agreed, yes, definitely. The committee has recently recruited a member from the neuro. So this will be not myself, but a staff member, a new person. Recruitment of a Lachine member has been postponed due to current uncertainty concerning the mission of the hospital. The committee will submit all future action plans for review to representatives of la Direction des Services Professionnels et la Direction des Soins Infirmiers for their input, as there are no representatives of these directorates on the committee. A complaint was made on the lack of lev person, which is currently being studied. Lev person is a lift, so reference was made earlier to bathrooms, not only for wheelchair, but for really anybody larger and heavier than a child who needs to be transferred from a wheelchair to the facilities is not available. I personally told them the answer that I got was completely unacceptable, and this could not be put on the back burner. So they're working on that. A
Good.
personal thing with me, because when you've had to change your adult child on the dirty floor in the hospital, they will have to do better. The committee shall be liaising with the Patient Education Committee. The committee has reached out to the EDI committee of the Research Institute to collaborate. There's an MUHC EDI committee with which the committee collaborates. There was just a presentation last week. Oh, I think that was the Lunch and Learn. It was excellent, just excellent, from Jordana about patient partnership and what they're doing at the Children's Hospital. It was like fabulous. There are discussions taking place on initiatives to have a web page for the committee. Environnement numérique d'apprentissage, MSSS, so that's a training. It's on digital environment. It was taken by 2 committee members, including a co-lead. It will not be made mandatory, but it will be highly promoted for staff, and especially all new hires working in patient reception areas. That's it. Thank you.
That's quite a lot. Thank you.
Sorry, can I add into what Joanna's saying, as I sit on that committee with her? That we're also looking into the deaf project that was brought up with the RVH. And also the issue of finding ASL interpreters, especially with what's going on, and how all departments throughout the hospital need to know how to contact an ASL interpreter for patients. To make them aware it's not the patients that has to find the interpreter, it's the institution that has to give them the interpreter. Because a lot of people think that it's the patient that has to pay for an ASL interpreter, and they're wrong. It's the hospital that pays for the ASL interpreter. And also to comment on the bathrooms, that's like a major issue we're having, because I'm a wheelchair user, and throughout that hospital, there might be 2 bathrooms on the Glen site that I can go into. So that's really something we keep arguing over. And as Joanne mentioned, they kind of put us off, but we bring it back to every meeting basically. And they're trying to tell us like there's really no money. There's not a bathroom big enough to fit a Hoya lift in it to attach to the ceiling. So that's really a major issue. And where to locate one for the children's also. So the bathroom problem is huge throughout the Glen. I just wanted to bring that to your attention. Thank you.
Thanks. I really appreciate that. It's hard for me to believe that there are no bathrooms, that they can't create a bathroom if none exists that can accommodate a Hoyer lift. But my concern about the accessibility committee is that it covers so many different sub groups, little communities. And I wonder if we wouldn't do better or additionally have specific advocacy groups that tackle, accessibility of bathrooms, mobility, reduced mobility issues, epilepsy, deaf community, each of these, as opposed to lumping them in. I'm worried. I don't know that much about the committee, but I'm concerned that they are covering such an enormous breadth of population that they're not going to be able to optimally serve any of the groups. I don't know. What's your experience with that, or what do you both of you think of maybe having specific targeted advocacy committees come out of that?
Yeah, I think it's a good idea, because not only are there so many, there's not the expertise, and I'm not pointing fingers. There's no reason why they should have the expertise, but nonetheless, it needs to be made available. So stakeholders with their relevant expertise, including access to funding, including access to accountability, including access to all the resources, real resources, not responses such as, well, the building, the bathroom was built according to code.
And it's
Because
an
the
outdated
code doesn't help the person
Right.
It's a very outdated code because that was the issue we brought up at the RVH Accessibility Committee that we formed. And going through the whole Glen with somebody from technical services. At the time, it was Francine. I can't remember her name, but we went to every bathroom in that hospital, from the children's sides to the adult side. And she couldn't believe that a bathroom that's supposed to be wheelchair accessible, you couldn't even get into it to turn around, let alone trying to transfer from a wheelchair. So I don't know. For the accessibility committee for the MUHC, I know it's mandated by the government, so they selected who they wanted to be on this committee. And it's only, they don't want it to be very big, which makes sense because the bigger, the harder it is to work with people. And you have to pick and choose what you're going to work on. So for myself and Joanne, we're always thinking of the patients. You know, that's not because you say this is a good task. It's a good task. It might be a good task to you because it's cheaper, but it's not good for the patient. So I don't know at all. And that's just my input. Because if you start looking at taking somebody from each disability, how many people are you going to have on the committee and how many things will be accomplished at that point?
Oh, I'm not considering adding that many to the committee. I'm thinking more of separate patient advocacy groups who can then either designate someone to the committee or go to the committee with a set of recommendations with a targeted approach. So I'm talking about doing something, I guess, separate from the accessibility committee, which is sounds like a legally mandated committee within the institution, but not a patient-centered advocacy group necessarily. So I'm just wondering how that would fit in and if those groups would be of value.
Like I said, the RVH already has accessibility committee within itself. So I don't know, maybe. But we worked on already, like with the parking, with so many issues that they have done. It could be a possibility. It could be something to look into. I know Bonnie was part of the project, bringing the project for the deaf in, and it went up to the central committee, and then it went over to the accessibility committee, which is good because now it might get a bigger step push forward. But I don't know, that's just my input.
Yeah. I was just concerned that accessibility cuts such a wide swath that I don't know, things can slip. You end up with a fantastic report with recommendations that gets pinballed around and never gets implemented. And if you had a targeted advocacy group for that specific community, would it be more effective? I don't know. Anyway, we can talk, a lot more about it in the future, but I feel like we need to optimize our efforts and our advocacy in a way that moves things forward, that doesn't just point out problems, but that actually moves towards implementing solutions. Okay, I think Joe had your hand up first and then Falk. Is that the right order? I'm not sure.
So I want to make sure that I understood this correctly. So in all of the new Glen, there is only 2 washrooms that are accessibility to wheelchairs?
Really big ones. Electric wheelchairs.
Wow. I imagine, and this is a brand new institution, and how could they have dropped the ball on this? I got to tell you, as a member of the patient committee when this thing was coming together, thank God I was on a lot of these committees but I can't believe this fell through the cracks. I mean, this is absolutely insane. So,
but you have to keep in mind, they said it was built to code, but it was an old code.
It was an old code, yes.
And that's where the problem comes in. So they did their part technically, but in today's society, things are built differently. So it's not built properly. So we can't say they didn't do their job because again, they're going to tell you themselves, we build it to code. But
yes,
it's a code from 1902, let's say. I don't remember what year, but it's going back many years. Let's be real.
That's right.
And that's where the problem comes in. And there's nothing there for a deaf person or a profound person with hearing loss if there's a code, whatever called, they're not going to know what's being said. There's nothing there to help them. So if you have to leave the hospital right away because of an emergency, that deaf person is watching everybody, not knowing what's going on. And there's no code for that. There's no code for that. So
Yeah, we have a lot to work on. Sure.
There's a lot.
Don't forget that there's no code for that, but this is not just the hospital, no code for that. It's across the province and all public places, basically. This is a very, very wide problem.
There's no question we are not uniquely
No,
malicious
no.
or poorly placed. Nevertheless, this is a
Oh,
health institution, and we need to have higher standards than the general public spaces elsewhere. I'm not saying that it doesn't have to happen everywhere, but I still think we do have to be held to a bit of a higher standard. Anyway, go ahead, Falk.
I just want to just what you said, Ingrid, and what Deborah said. It's a different way of seeing things. And I think as models, you can see the other 4 institutions that are like us in the province, where you have one hospital as a governance. And that would be the CHUM, that would be the St. Justin Hospital, that would be a few other hospitals. And what they do is they have special interest groups. And the special interest groups, particularly the CHUM had a special interest group. They had the same problem. The CHUM was even several billion-dollar investment, and they had no handicap washrooms. But a special interest group got involved, and the CHUM actually resolved the issue. And these special interest groups don't have to be in our area alone, because the CHUM got involved province-wide with partnerships as well. So I'm just throwing that out there. I really like Ingrid saying, where you're saying, take the issues like the accessibility, the washroom, do some special projects, the death that Diane so eloquently states. Those are special projects. And I think that's what you have to determine which ones. And your partnership isn't, and your budget isn't only limited by what the MSS for the MUHC is. You have foundational things. The Jewish General, for instance, has their own committee, but it's part of the CSIS West. But they use the foundation money to do special projects like apps that cost tens of thousands of dollars. So what I'm trying to say here is, I think your idea is excellent. You should be very malleable on how we do it. And I think that's where guidance can come from the former central committee on putting it together and choosing the things. But I do think we should look at not only looking at it from the RVH or the MGH, look at it as a partnership within ourselves and a broader partnership, what the MSS really is. There are 800-900 members. And I strongly suggest a few of you go to the RPCU Congress, where projects that are dynamic cross 10, 15, 20 committees together, enacting some serious change in our system. So that's all I bring to the table is look at it in a broader sense. Don't only look at it in our sense, and really choose special interests rather than saying it's an RVH accessibility. It is with the bathrooms, but look at it that many hospitals, modern hospitals, have had the same issues, and maybe look at how some of those hospitals made solutions, because they're a step further than we are today.
Thank you, Falk. That's helpful. Thanks. Elizabeth, and then Deborah, and then Diane. Is your hand up again or still? Again. Okay. So Elizabeth, then Deborah, then Diane, I think was the order.
Okay, thank you, Ingrid. I just want to chime in regarding the code that the MUHC has been saying that they built the Glen, with and it was up to code. There is a report, and perhaps Shawan can find it for you, dating back in 2016. Maybe the report was finalized in 2017. I don't recall, but I remember being in touch with a person that did the report. Her name was Tiu, T-I-I-U, Poldma, P-O-L-D-M-A. And she, at the time, she told us that it was, the Glen was built by the old code, which was 25 years old. just to tell you, and I believe she put it in the report. So just for some background information.
Uh, It may be an obvious question. So they built it according to a code that was 25 years old when there had been a more recent code, or no?
There
That
was
that
a
was
recent code, but they
that
went
was.
with an older code. This is why there were so many issues at the Glen. They built a state-of-the-art institution with so many, issues, with lack of accessibility all around. The bathrooms, the counters, in OPD, you name it, like everything was out of sorts.
Okay, that makes no sense to me that you can justify saying I built it to code if you're not using the most recent code. That's akin to a doctor saying, well, I gave you the standard of care treatment for 1925.
Well,
mean,
this is
I can't believe they would have the nerve to actually defend themselves saying they built it to code if there was a recent code that they weren't adhering to. That's bizarre. Anyway,
Ingrid, this is my sort of rendition and remembering, what happened back in 2016. So, and I remember too, because she's also a personal friend, she was telling me that, I mean, what is this? This is an old code, they're building a brand new hospital with, with old standards, so you may want to look at that report if ever, this is something that you want to take on with the MUHC.
I don't think I want to look at that report, but I get your point is taken.
Thank you.
Go ahead, Deborah.
I remember before they built the new hospital, because it was a PPP, everything had to be precise because they couldn't make any changes. So there were interviews with all of the departments, all of the physicians and the nurses and the technicians about exactly what they needed. And I'm wondering, were there no interviews with patients regarding the accessibility to washrooms? Did they skip that, or has it been ignored, or what happened?
We have people.
I don't know, but I will tell you that it's true that they did interview a very close friend was the nurse educator for Hem-Onc at the Old General, and they interviewed that department very thoroughly and exhaustively of what they need, what the patients for the inpatients rooms, for the clinics, and then they built, and at the later stages of building, they allowed teams to come in and tour, and absolutely zero of their lists of priorities that they outlined were adhered to. So maybe they interviewed patients, but anyway, that was happening a lot. And I know from a physician's perspective as well, there was much input that was ignored, to the point where people asked if the architects were actually healthcare architects, for healthcare institutions, or for, aluminum smelters, because there was so much that did not make sense. Anyway, sorry, Diane, go ahead.
The CHEM was mentioned for the accessibility of the bathrooms that wasn't there. They did have accessible bathrooms, but there was a problem with their doors. That was their problem. I was in and out of the CHEM when it was done, and I had taken videos and brought it back to the technical services at the Glen to show them how their bathroom worked. What they did was just minor little things that they fixed their accessibility. Their bathrooms were big for wheelchairs. I was able to go in with my wheelchair with no problem. We don't have big bathrooms. They had the big bathrooms. They just had to adjust a screw to make the door open. You could push it open. It will stay open long enough for you to go inside, transfer it. You could turn around, do a full 360 in their bathroom. At the Glen, it does not have that. So there's a difference for an accessible bathroom, but the size of the bathroom. So that's one of our main problems, that a lot of people don't know the problems of the bathroom accessibility.
Well, even those of us with just some muscle weakness, with it just, toilet heights, you don't realize until you have an issue. So I understand that, but it's disturbing given the runway sized hallways everywhere, that there is a shortage of space. bathrooms. It's troubling in any case. Anyway, I think we could go on about accessibility indefinitely, but I want to make sure that everybody gets through their projects and their presentations. So Jean, I will leave it to you for the
Okay. All right. I guess I really think to base what I'm going to say on the needs of the people here. How many people know that there is a patient's rights brochure that has 5 languages, and we're trying to begin, actually not begin, we trying to continue. Siobhan has really helpfully started us off, sending all around. They have Inuktitut, Cree and Mohawk languages, and they were made by a very bilingual, trilingual, 5-language group. And the 3 co-chairs were Bonnie and myself, and Linda DeLille, who was on the administration of Cattery. So I want to know who needs to know a little bit from the beginning in order to sort of understand this, on how many people have one of these in their pockets. Well, maybe not.
Maybe ask one of those questions at a time.
Let's start, Danielle. Danielle, I got to tell you, I didn't know who you were until I saw you on that video. Man, you were powerful. I love that Lachine video was it on the weekend, on Saturday? Yes. Congratulations. You've done us proud. What's your question about this?
Well, you asked who.
No, I'm asking Danielle.
No. Oh, sorry.
Yeah, Ingrid's on the right track. You asked if anyone had one in their back pocket. I do have one here nearby.
Okay. Oh, that's good. Is there anybody that doesn't know about this? Is there anybody that's wonderful news? I'm so pleased. Is there anybody that doesn't have a couple available? And I guess I'm just going to say I cannot pass them through the screen. But the person who has a few left, and this brings us to maybe our first request from whatever name was chosen for the group that started the brochure, is Siobhan has the supply. And we also should, I won't go into the history of it then. I told you that everyone was distressed about the situation for Indigenous patients. We wanted to make something that would welcome them. We can't change behavior in the hospital. We can change the learning of patients that come in, Indigenous patients, parents of Indigenous children, elderly Inuktitut speaking people from the north. We can change their feeling about the hospital by knowing that there's some place they can go to talk about making their hospital experiences better. So I'll use the time, I'll use the other bit of the time to talk about going to the Art and Heritage Vernissage last night. Harvey and I were there. So was another group, a good group. For me, it came full circle, because when we started our little group around making Indigenous patients welcome, we thought, oh, Art and Heritage, they're still putting out Wedgwood cups in little spaces, and that's not going to talk to the Indigenous people about feeling at home. So that was a few years ago, and things have changed. And what's his name? I gotta remember his name. Dr. Jonathan Meekins, who's head of Art and Heritage, and Ali, who's the curator, Ali Kirsch. They are really on board with making the hospital as appealing as possible for our Indigenous patients. And this is the folks from the north and the urban Aboriginals. Hey, Harvey? And so I'm going to tell you two more things while I have you all. There is a group, there will be some sort of celebration on June 21st, which is, I'm going to say Indigenous Day, but I can't remember. June is really for indigeneity. And then at September 30th, there'll be something else. So although that was missed in the last year because we lost Marie Sidurska, she of Cultural and Interpretive Services, because she retired, and we didn't have anybody able to do that. So there will be something this year, and we will continue to work on that. I don't think I'll say anything more. We've got 34 minutes left.
Thanks very much, Jean. Also, just a note that the pamphlets, of course, we do have some paper copies, but there's a link to the virtual form, the electronic form on the Patients Committee website on the MUHC page. And we're going to be expanding our social media presence in general, and we will absolutely make sure that there are links to that. So thank you so much. It's an amazing project and it looks fantastic. So I appreciate it. I'm just going to actually switch, since we're on the topic, and go straight to Harvey to talk about traditional foods. And then I'll get back to Bonnie and Lawrence after, if that's okay. And indeed, we only have less than 25 minutes left, so I just want people to just be a little bit aware of time. Harvey, are you ready to go?
Yes. Can you hear me?
Yes.
Very well.
Yeah. Okay. Yeah. Also, I'm very enthusiastic in terms of providing what we call country food. The impetus, I guess, would be using food as a form of healing and reconciliation. As we know that traditional foods, either Inuit or First Nations, we have better outcomes, health outcomes, as the food that is being served, the hospital food. Of course, I don't say it's not nutritious, but it's very foreign. As an impetus, there was one patient that did not want to eat because that he was being reminded of residential school, so he didn't eat the food that was given to him. So using food as a form of reconciliation, it's nothing new. There are initiatives in other parts of Canada. I approached food services and the person that is responsible for providing meals to all the patients of the MUHC, and they are open to providing items in the menu as an act of good faith. Let's say we had a bacon tasting, well, not just ceremony, but an action that was done last year. Well, actually about a year and a half ago, actually, at the Montreal General Hospital. So nurses, doctors, and a lot of us came to select a particular, I don't say brand, but the quality, the look, the shape of it, the how it tasted. Yeah, it's organic. Yeah, so we decided. Well, they decided to choose one variety, I guess you'd say, because of the ingredients of that because of the patients with salt and all this stuff. So what they did was last year during Indigenous Day on June 21st, it was served at available at the cafeteria first, and it was very great, very good to see that. It's a step in the right direction, and the food provider of the hospital is going to be adding more. Currently, there's been a contract. We'll be renewing the contract where the provider will be given direction of providing food for Indigenous patients. So last night during the vernissage of the donation that was given to the Children's Hospital, we had bannock and tea with the guests from Ulivik. Ulivik is a home hospital hotel where Inuit patients are housed, and they're driven to all the sites of the MUHC and other clinics and hospitals across Montreal. And Ulivik, we had a guest from the Ulivik. We had two, and they were in my estimation that they felt like validated. Like when they saw this piece of art on the wall at the waiting room on the fourth floor of the Children's. It was something to see, and I mean it's a step in the right direction. In terms of adding more food, the Mohawk also have what we call Three Sisters soup. That will be added on as well. But other food that Indigenous eat, obviously there's a cost to it in terms of even for berries such as strawberries and raspberry, all kind of berries. I'm very optimistic in terms of the initiative that is open to the food services. I guess there's more to come, because for them, when they even eating bannock, for anybody for a person that we've been eating that for thousands and thousands of years, instead of being given white bread or brown bread or whole wheat bread, and it's something that is really connects with your mind, the body, and soul. So it's quite a great outcome, I guess. Anyway, thank you.
Thanks so much, Harvey. I mean, there's a reason comfort food is called comfort food, and food plays such an enormous role in all of our lives and all of our cultures, but particularly having lived in the North for 20 years, bannock itself is a staple food in our house. And there are so many meanings imbued in what we eat. And I'm so thrilled that food services in the kitchen was, at all receptive to this, particularly if it involves a higher cost. So bravo and onward, because it's, when you're seeking treatment thousands of kilometers from your home and isolated, to be able to at least offer something like that is really fairly simple, it's priceless. So I love this project. Thank you so much for working on it. Bonnie, I realize the deaf project you want to talk a little bit about, and I should have piggybacked onto when we were talking about accessibility, but
that's okay. Okay, that's okay.
And again, there's 15 minutes left, and Lawrence also wants to speak. I don't mind sticking around a little bit after, but I don't want to lose people and have people not have the audience.
We'll do as fast as we can here. Okay. First of all, I just want to let you know that the deaf issue really made me feel very strong about it as a personal experience. The one thing that happened is I was very friendly with a couple of people who were both deaf. The woman had a heart attack. She was taken to the hospital. The man was left at home. He's deaf now. He doesn't know what really happened. The hospital can't communicate with him, right? He went to the hospital the next day and found out she died during the night. And he didn't know she had a heart attack. And I mean, how could you do that? So this really put me on the stand here to do something about that. And now when we're dealing with the deaf, there are two issues. The one is, number one, to understand. And it's an educational thing that people have to learn. It's a different culture. And there's different things that go on here. And on the other thing is, you have, just like with the handicap, is accessibility. I've been in all the little doctor's offices and this and that, where they're calling the patient. Doctor comes out and calls the patient, Stamos or Distunis, come here. It's your friend. They don't hear. They can't hear it. They have to have either a number with a number up there. It's not a big thing, but I think that's something we have to look at the hospital. Because patients have often said that they were just sitting there and, at the end of the thing, the nurse says, oh, well, what happened? Where are you? So that's the issue. But I'd like to bring up to date the work we have done with the, we work with have done and tell you about the work with the users committee. We first started and we supported the Canadian Deafness Research and Training Institute to look into the whole issue of deafness. So I could just give you this report, bring you up to date, okay? The issue of improving the access for the deaf, care for deaf, was introduced to the RVH Users Committee in 2018. Dr. James and Dr. Paige McDougall of the Canadian Deafness Research Institute were contacted and made an initial presentation, including the relevant understanding of the needs of the deaf community in accessing healthcare. The Canadian Deafness Institute is a national organization that focuses on issues concerning deafness and has an interest in furthering the understanding of information surrounding deafness and communication in hospital policies. Since 2018, the Canadian Deafness Institute has been carrying out research surrounding deaf healthcare access policies in hospitals across Canada, providing a comparative framework for implementing best practices at the MUHC. Since that time, the project, supported by the Users Committee, has been developing policies and procedures to improve the access for healthcare for the deaf community. A report from CDRTI, Canadian Deafness Institute, detailing activities as well as outlining 10 concrete recommendations have been made and completed, and then they are available to us. With assistance from the Department of Shared Continuing Education at the MUHC, the first of planned series of e-learning modules were produced, which will be made available to all levels of staff and professionals working at the MUHC. The e-learning series will involve making appropriate e-learning modules for circulation within specific departments of the hospital. Module 1, this is what it includes, provides an animated introduction to deafness and the special needs of deaf patients in accessing healthcare, and explains the legal rights of deaf persons to sign language interpretation in the context of healthcare in terms of policy stipulated under the Canadian Healthcare Act. Now that module has been completed and we've seen it. Module 2 is now completed. It outlines the provision of interpretation interpreting services to deaf patients. This animated e-learning module explains the use of various methods of sign language interpretation, such as video relay services, VRS, and video remote interpreting. And of course, these are both things that you could use with a cell phone, with a any of our modern things here. CDRTI has established a relationship with the we have an establishment with the Access Committee, as we were speaking about before, and now it is part of it, and now it will be included with the Accessibility Committee for their action plan. So, however, I think this will need a little discussion. The members of the deaf ensure that all materials are generated, are designed to meet their needs. That's bottom line, is that anything we've made for this project have been given to deaf people to see if it's understandable and okay. Now, the Canadian Deafness Research Thing has provided an excellent, comprehensive 50-page final report that includes best practice, suggestions, and recommendations for the future development of accessible healthcare to the deaf community. Now, the next step to this project is to have the MUHC follow up on the basic recommendations for the successful improvement of the access to healthcare for the deaf community. The most recent report from CDRTI lists the suggestions of best practices and recommendations. Hopefully, the project will continue with support from the MUHC for implementation of deaf access materials and resources. The deaf community deserves the right to accessible healthcare as stipulated in the Canada Health Act. That's really important. The implementation of CDRTI recommendations needs to be recognized and established. And we have to also say that the MUHC is well positioned as a leader for improving equitable deaf access to healthcare across Canada. None of the hospitals across Canada have a program, and this is terrible. So let's be the first one. Now, I think I have to just say that there's this issue where we have to educate the staff, all staff at different levels. People have to be aware of the culture and what you could do and how you could do it. And then you have the problem of having the actual, I'm losing my thing. Patient is in a hospital. Nobody understands them. They have to know something. You have to have places, ways of contacting deaf people from the hospital to the patient. The doctors have to know how to contact them, where to contact them. You know, there's a whole other educational thing that it's a multiple thing we have to do. So just hopefully it will continue, because this has been going on for so many years, and we sort of hear all the problems that there are.
Yeah, I understand there's multiple levels and it is not easy. There are no easy solutions for any of the things that we are faced with and challenges. And I think that's no reason not to forge ahead and do the best we can to move things forward at a pace that is reasonable. So thank you. Thank you for that.
Yes.
2 more minutes, Lawrence.
Okay, try to be very brief.
Sorry, it's my fault for not managing time a little bit better. I apologize. So I hope people stick around for Lawrence's presentation.
We have a special program at the Neuro. It's called the Greetings Committee. And the volunteers visit the patients at the bedside. And we inform them of the patient's rights. We give them the pamphlets. We take complaints. And we go often to the nurse managers and tell them of the problems that patients are having. So like Tom said, walk the floors and build relationships with the nurse managers. Getting back to accessibility again, we had a project which has finally come to fruition. It took 5 years to change the handicap entrance to the Neuro.
At last.
At last, you know, the patient entrance is on a hill, and a person in a wheelchair in a snowstorm or an icy sidewalk, it's very difficult to get into the hospital. So now the patients can enter the hospital at the north entrance of the building. We had the bricks shaved down. Wheelchair can run smoothly into the building. And we also had signage put in the clinics to advise the patients and their families that there's now a new access entrance to the hospital. That's it.
Yeah, bravo. That is a huge, huge improvement.
5 years.
No, it's disheartening, but for all those of you at least here, and to spread the word, I don't know if everybody knows, there's handicap parking behind the neuro where the ambulance entrance is.
Yes, but very limited.
Very limited. And the other problem is for COVID, they closed that door. So even though you could park there, you had to go all around. So anyway, I'm going to be there Thursday, and I was very curious to see if that door had reopened.
Yes, we're supposed to get another few parking spots at Molson Stadium. There's negotiations with McGill and the MUHC, and they'd be able in that wheelchair to come enter the building at the north entrance.
I mean, the ultimate plan is that the ministry has approved plans for the neuro to move, but they have not funded it. And with everything on, it's not going to happen probably in the next 10 years, but there is space at the Glen site, and there is the mission. I mean, there is the formal go ahead without the actual practical go ahead. So that will be improved. But in the meantime, there are many things that need to be done. And thank you for getting them done, because these are the types of things that really improve the day-to-day life of a wide swath of patients. So it's really well done. We appreciate it. Anyway, we have to wrap up, but I have to say this has really been fantastic. First of all, to meet people, to put some faces to some names, to put some names to some black boxes. But I really, it's impressive to see what's been done, all the work, and I hope that we are all prepared to move forward and keep working, irrespective of title of committee or whatever you want to say, to get things done in the best interests of all the patients in our community. I hope that we will keep lines of communication open in both directions. We will not wait for invitations or for meetings, but we'll speak to each other in between and exchange ideas and move things forward. I think that will really expedite practical solutions at a pace that needs to happen. So thank you all very, very much for joining. I don't know if Deborah or any other UC member has anything else to say, or if anybody else wants to say anything.
I'm just wondering, we didn't specify a question period, but somebody's just asked if we do have a question period.
We were supposed to have a question period. I do not mind sticking around. I don't, but I'm concerned that people will be leaving, but I'm open to continuing this if people want to stay on. I didn't see that, but I'm not managing the chat very well.
No, there's nothing in the chat here. Did anyone have specific questions?
Oh, I see. Okay.
I guess for me, I'm just not sure with the RVH Glen group. Are we going to be a group again? The chest hospital was not part of that. We didn't. I can't remember if we had somebody from the chest hospital. Are we representing a space, or are we going to be joining like other interest groups, for example, Indigenous? So it's, for me, I'm leaving really encouraged by how this meeting went and who showed up and who spoke up. And I'm just not sure for the groups that I've been involved in, what the next steps will be, but maybe we should just call another small meeting next week and talk
We-
about it.
We can do that, or you can speak to us, outside of the meeting. I mean, ultimately, there's certain issues that are distinct to certain buildings. So it makes sense to have a committee in a building site. There are certain issues that are distinct to communities or medical conditions. So I think there's overlap between them all. So I don't think there's really a right or wrong answer to that. I think you just have to address a specific project and find a working group that is appropriate for that project. Sorry, go ahead, Joe.
I just wanted to thank everybody for showing up. I got to tell you, it was very informative, and I'm glad to see that things are moving along. Remember that we're there as a team partner, right? I think the way Ingrid started this meeting today, I got to tell you, I wasn't ready for it, and I loved it, because I think it's about time that people recognize what's gone on for too long. Anyhow, all I can tell you is that I'm very encouraged too. It's beautiful seeing all these stories and the passion that's in these groups and committees. And believe me, this users committee will be there to support you in every single way possible. And when it comes back to this brochure in the indigenous languages, I think it's such a beautiful thing that took too long to make. So the key is, yes, obviously this is going to be one of the things that we need to support when we run out. I think we only have a box or two left. Yes, obviously it's going to be one of the things of the top priority. So anyhow, remember, we're there as partners and not to dictate to anybody, and we're there for you. That's it.
Thanks, Joe. Danielle.
Yeah, I just wanted to also say thank you to everybody. It was nice to put faces to names. I talked with Tom, and I'll be emailing you again, Tom, regarding the little kits. We were supposed to get together, and I want to pick your brain about that, what you have in those kits, because we were interested in circulating them at Camille Lefebvre. But it's nice to see everybody, and I will contact some of you folks who had great ideas, get my little brain thinking, and I'd like to hear more about it. But thank you all for coming. Nice to meet you.
Thanks, Danielle. And Sarah.
I'm echoing, thank you so much, all of you, because it has broadened my view of what we all are doing together, what all of you committees have done. I am in awe, and thank you.
Yes, Danielle, we'll get in touch, and I'll definitely let Camille Lefebvre have some, no problem.
Okay, so thanks to you all, and please be in touch with any concerns at any time. Obviously, we juggle, we're not always available because of health issues and treatments, etc. But somebody is available, and we do our best to be as responsive as possible. So please don't be shy to reach out, and go enjoy the rest of this beautiful sunny afternoon.
Thanks, Ingrid.
Thank you.
Thank you, everyone. Bye.
Thanks,
Bye-bye.
everyone.
Bye.
Thank you,
Bye,
everyone.
everyone.
Thank you.
Take care.
Bye-bye.